Distinguished participants, first, let me acknowledge and thank Switzerland and Sierra Leone for co-hosting this event with the Global Commission on Drug Policy on a very important topic, and that is access to essential controlled medicines 5 years after UNGASS. We meet now as the general debate of the 76th session of the UN General Assembly is underway, and it's my pleasure to announce to you a great panel of speakers. First, we have Ambassador Lansana Gberie, Permanent Representative of Sierra Leone to the UN in Geneva. The ambassador has been extensively speaking on the need to reform drug policies in Sierra Leone and in West Africa as a whole. In 2014, in conjunction with the Kofi Annan Foundation, he co-authored the West Africa Commission on Drugs report called Not Just in Transit. Next, we will have Dr. Gitahi, Chief Executive Officer of Amref Health Africa. Dr. Gitahi is a passionate advocate for equitable and universal health systems. Under his leadership at Amref, he's been instrumental in advocating for governments to ensure affordable access to medicines, especially for vulnerable populations. We have Ambassador Félix Baumann, Deputy Permanent Representative of Switzerland to the UN in Geneva. Ambassador Bowman calls for a health and human rights-based approach to drug policy. In February this year, he co-hosted the first Brandenburg Forum in Geneva, which aimed to build bridges between the drug policy and human rights regimes of the UN. We have Dr. Felicia Knaul, member of the board of the International Association for Hospice and Palliative Care. Dr. Knaul's work focuses on raising awareness of disparities in accessing opioid medicines for pain relief and palliative care, and she is the author of more than 250 academic and health policy publications, currently serving as director at the University of Miami Institute for Advanced Study of the Americas. Then, to conclude our distinguished participants today, is Dr. Tedros, Director General of the World Health Organization, who, prior to his election to that position, served as the Foreign Minister of Ethiopia. So, to come to today's topic. For the past 50 years, global drug control policies have been based on general principles of eliminating the production, trade, and use of any illegal psychoactive substance from the world. They have been pursued through fierce law enforcement and even through militarization in some countries. But we at the Global Commission on Drug Policy have been denouncing such policies as unscientific and unrelated to people's cultures and choices. They've resulted in a large set of what the United Nations describes as unintended consequences. And one of those is the global crisis of inequitable access to controlled medicines for pain relief and palliative care. In 2015, the Global Commission published a report titled The Negative Impact of Drug Control on Public Health, the Global Crisis of Avoidable Pain. Back then, an estimated 5.5 billion people, rather more than 75% of the global population, had poor or non-existent access to opioid analgesics, particularly to morphine. 92% of the world's morphine supply was being consumed by just 17% of the world's population, with most of the consumption concentrated in the high-income countries. Methadone and buprenorphine are substances used in opioid substitution therapy, yet these were estimated to be available for only 6 to 12% of people who inject drugs. These substances, like morphine and other analgesics, are controlled under the UN Drug Control Conventions and included in the WHO's model list of essential medicines. The UN Single Convention on Narcotic Drugs, 1961, affirms in its preamble that the medical use of substances controlled under the treaty continues to be indispensable for the relief of pain and suffering, and that adequate provision must be made to ensure their availability. But many countries have failed to fulfill that objective. Instead, fears over dependency on controlled opioids and over their potential diversion into the illicit market have trumped concerns for their medical availability. That's despite the fact that research, while limited, has shown that among patients with no history of substance misuse who were treated with opioid analgesics, only 0.43% misused their medication, while just 0.05% developed dependence. As we discuss how to improve access to controlled essential medicines today, we should acknowledge that the level of visibility given to the issue has improved a lot since the 2016 UN General Assembly Special Session on Drugs. In 2019, UN member states reiterated their resolve to address existing barriers, including affordability, to ensure access to and the availability of controlled medicines. In addition, and positively, WHO's Expert Committee on Drug Dependence has met each year since 2014 after years of inactivity due to lack of funding. It has concluded in recent years that substances like ketamine and tramadol shouldn't be internationally scheduled, as that would drastically restrict access to them as anesthetics and for pain relief in low and middle income countries. The availability of opioid substitution therapy has improved in the community, and particularly in prisons. It's now available in prisons in Bulgaria, France, Greece, Italy, Portugal, the United Kingdom, and some other European countries. And in 2020, Kenya opened its first opioid substitution therapy clinic in a prison in Mombasa. But still, limited progress has been made in ensuring access to pain relief where it's most needed, and a very limited number of people in need are receiving OST. In 2010, the International Narcotics Control Board reported that more than 80% of the world population have insufficient access to analgesia or have no access to analgesia at all when they're suffering from pain. The situation hasn't improved since. In 2020, WHO noted that due to unnecessary restrictive regulations, the percentage of people globally who receive the palliative care they need is as low as 14%. Conversely, the same medicines are being overprescribed in other countries, such as the United States, which has contributed to the opioid overdose crisis in that country. One of the Global Commission on Drug Policy's main recommendations is always put people's health first and prioritize access to essential medicines for pain relief and palliative care. Unfortunately, when interpreting the UN Drug Control Conventions, countries have been prioritizing the obligation under that to prevent abuse over and above the obligation to ensure availability for medical care. So, in concluding, let us not forget that under international drug control and international human rights legal instruments, states have an obligation to ensure that controlled medicines are made available to their populations. I now wish to hand the floor to our other speakers. And first, I will pass the floor to Ambassador Lansana Gberie, a long-time partner of the Global Commission and the West African Commission on Drugs.
Excellencies, distinguished delegates, ladies and gentlemen, I'm honored to co-sponsor and participate in this meeting discussing access to essential controlled medicines. I have been active in efforts to forge humane policies towards narcotic drugs for many years now. In 2014, I was the lead author of a landmark report produced by the West Africa Commission on Drugs, which had been brought together by the late Kofi Annan. So let me thank the panelists, the Global Commission on Drug Policy, and in particular, Ms. Helen Clark, who brought this issue to Africa and to the world and to the international debate 5 years after the commitments made at the UN General Assembly section on drugs, UNGASS, in April 2016. The UNGASS gave unprecedented visibility to this issue. In the outcome document, an entire chapter was dedicated to controlled medicines with detailed recommendations aimed at, and I quote, addressing existing barriers, including those related to legislation and regulatory systems in accessing controlled opioids for pain management and palliative care. Internationally controlled medicines such as morphine, diazepam, and midazolam, which are listed as WHO essential medicines, are vital for pain management, palliative care, surgical care, and anesthesia, as well as the treatment of drug use disorders, mental health, and neurological conditions. Yet, progress since UNGASS has been very modest, in particular for low-income and middle-income countries. According to the WHO, each year over 5 million people suffered moderate to severe pain because of the lack of access to control management drugs. Currently, Africa is experiencing a shortage of inadequate pain management and palliative care medicine. According to the 2021 World Drug Report, there are just 4 standard doses of controlled medicines to relieve pain available daily per million people in Western and Central Africa, compared to 31,826 doses in North America. I'll let that sink in. And according to the 2021 World Drug Report, patients have been affected very badly in regions like Western and Central Africa with the outset of the COVID-19 pandemic. And now released just a few days ago, a joint INCB, UNODC, and WHO statement on access to controlled medicines in emergencies call on governments to facilitate access to medicines containing controlled substances in emergency settings, including during pandemics and the increasing number of climate-related disasters. Despite a strong commitment made by member states to improve access to controlled substances for medical and scientific purposes by appropriately addressing existing barriers in this regard, including those related to legislation, regulatory systems, healthcare system, and affordability, progress, however, remains to be limited on the ground. We must note that improving equitable access to controlled medicines, in particular for the management of pain and for palliative care, is in line with the objectives of the 3 international drug control conventions. Ensuring access to essential controlled medicines must also be at the heart of national drug control policies that play a significant role in limiting access to internationally controlled medicines. Today, my country, Sierra Leone, imports 500 milligrams to 1 kg of cheap powdered morphine for pain treatment, which is very obviously inadequate to meet the demand for essential medicines needed for pain management. Yet these medicines are really inexpensive and are patent-free, but they are still routinely denied or severely limited in many countries. The explanations to the striking gap in supply and demand are complex and include misperceptions, fear of addiction and deviation, drugs costs, and inadequate funding, complex drugs procurement procedures, and of course, drug control policies. Extraneous laws and excessive regulation perpetuate this situation and are among the main barriers in many countries in Africa, including my own. And this comes at a high cost. They include unnecessary suffering of the most vulnerable, children and the poorest. Therefore, African countries must be prepared to adopt more efficient and balanced drug policies in line with the SDG goals and the African Common Position on Controlled Substances and access to pain management drugs. It is crucial to work for the achievement of an internationally controlled drug system. Such a system should be focused not only on illicit use and the prevention of abuse of controlled medicines, but also on a more balanced approach. It has to be more balanced. Our region cannot afford repressive drug policies that have proven to be ineffective and harmful to people. We must be more humane in our approach. So it is time to rethink our policies and work towards addressing the fundamental challenges and not exacerbate them. The choice of balanced national drug policies that are respectful of human rights are the key to the future of Africa. Let's remember that access to palliative care and pain relief is a health, equity, and human rights imperative that can no longer be ignored. I thank you all for your attention and good luck with the conversation. Thank you.
Thank you, Ambassador, for your contribution. And now it's a pleasure to give the floor to Dr. Gitahi from Amref Health Africa.
Well, thank you, Prime Minister Helen Clark, for having me here and for having me contribute to this important debate following UNGASS 2016. The African continent, and specifically Sub-Saharan Africa, faces an increasing burden of pain, especially because of increasing cases of cancer and a high burden of HIV and AIDS. This has become a major public health challenge because pain itself is a major public health challenge, but it doesn't have to be so. And why is it so? It is because whereas science provides solutions for us to reduce the burden of pain for individuals across the continent, there raise incongruence with policy because most policymakers suffer opiophobia, and so do health workers who fear that patients are going to get addicted, that opioids, specifically morphine and others, are going to be diverted. And this opiophobia, policy opiophobia, has resulted in extremely low access of pain control medication to those who most need it. This has resulted with Sub-Saharan Africa having a very high burden of pain, but the lowest consumption of opioid medication for pain control, as low as 50 doses per day, compared to what may be the good standard of at least 200 doses per day, with continents like, or countries like North America consuming up to 14,000 doses per day or in excess of that. This doesn't have to be so, but there are many challenges that we need to overcome. These are challenges of ensuring that the African countries achieve universal health coverage that is supported by equitable access to medications that are mapped on the agreed essential services of health services or package, and supported by essential medicines as defined by the World Health Organization, as defined by national essential drugs lists. But we must also overcome this policy opiophobia. And the only way to overcome this is to ensure that beyond ensuring that there is equitable access to pain medications as defined by science, we must support this with proper public health policy, and at the same time, we must put people at the center. The biggest challenge is that those who are most affected and who have lived experiences of the pain burden are least represented in the policy making boardrooms. This must end. We must have people-centered universal health coverage that is cognizant of the role of palliative care in achieving universal health coverage beyond promotive, preventive, curative, and rehabilitative care. And this can only happen if we put people at the center. And that time is now. We cannot continue to have African people experience an excessive burden of pain when science provides that this doesn't have to be so. Time is now. Thank you.
Thank you, Dr. Gitahi. The Global Commission very much values the work of civil society and communities around our world. I now have the honour to give the floor to Ambassador Bowman of Switzerland.
Honourable speakers, excellencies, dear participants, Switzerland is honoured to be co-sponsor of this virtual high-level side event, as access to and availability of essential controlled medicines is a top priority of my country. Before I begin my remarks, please allow me to express Switzerland's profound appreciation for the work of the Global Commission on Drug Policy, for its dedicated commitments in addressing the various and complex challenges of the world drug situation. 5 years ago, a special session of the General Assembly on the World Drug Situation was held in New York. The outcome document of this meeting contains considerable progress for a global drug policy centered on the human being, his health, and his rights. This document recognizes that access to and availability of controlled medicines are a principal component of international drug control. It also encourages member states to remove the wide list of barriers hindering access and availability, for example by reviewing domestic legislation as well as regulatory, administrative, and assessment mechanisms, or by regularly updating the model list of essential medicines of the World Health Organization. Essential controlled medicines are important in the treatment of drug dependence. This is why Switzerland created a legal basis for substitution-based treatments in 1975. However, essential controlled medicines also play a crucial role in various fields such as maternal health, neurology, and palliative care. With this in mind, we cannot accept that people are suffering even more because of the lack of access to and availability of controlled medicines. Switzerland is home to some of the world's leading research-based pharmaceutical companies and chemical industries, has been active in supporting facilitated access to controlled substances, general research, and the development of medicines containing controlled substances. However, it is important to underline that this support is not about legalizing drugs, but about access to certain substances for medical use. Globally, some progress based on the measures contained in the UNGASS outcome document can be welcomed. The INCB supports efforts to improve the situation through the International Import and Export Authorization System, with Switzerland as a major contributor. The model list of essential medicine of the WHO is also regularly updated. However, and despite the general increase in access to and availability of controlled medicines before the pandemic, it has been clearly shown since then that there is an absolute need to increase this access and maintain it under all circumstances. Both the INCB report of 2020 and the UNODC World Drug Report 2021 highlight that the inequalities and barriers in the access to and availability of controlled medicines around the world remain striking. This deny relief to patients in severe pain with serious consequences for them and their families. The CND also recognizes the difficulties encountered by member states on this matter and the international guidelines on human rights and drug policy developed with financial support from UNDP, Germany, and Switzerland confirm that access to controlled medicine without discrimination is a key element of the right to health. Honorable speakers, excellencies, dear participants, as you certainly know, Switzerland is convinced that the world drug situation cannot be discussed without addressing its health and human rights aspects. In Switzerland, as well as globally, we are still facing various challenges that have become more apparent and have worsened by the pandemic. We need to enhance our cooperation and base our strategy on a multi-stakeholder approach, including civil society, but also the various UN locations addressing the world drug situation, such as New York, Geneva, and Vienna, to effectively respond to these challenges. Sharing experiences and views is always instructive to discover innovative solutions, and we are looking forward to listen to our honorable panelists. Thank you for your attention.
Thank you, Ambassador, for your important contribution and for Switzerland's support to this very important area of policy. Let me now give the floor to Dr. Felicia Canal, one of the authors of the Lancet Commission on Palliative Care and Pain Relief report.
I want to thank the Right Honorable Helen Clark, Chair of the Global Commission on Drug Policy, for inviting me to represent the International Association of Hospice and Palliative Care at this important side meeting of the UN General Assembly. I want to share with you information on what is the global pain divide and some ideas on how we can close it. First, the global pain divide. The bottom line, the poorest 50% of people in our world have access to only 1% of the opioid medicines. The map is showing the difference between access and need, access, equivalent morphine, and need, serious health-related suffering and palliative care need. You see an engorged Canada, United States, and Australia, and a disappearing developing world. You barely see Latin America, Africa, or Asia on this map. Russia and China are tiny. Western Europe is about the size we think it should be. Now, need is only increasing over time. We see that the global burden of serious health-related suffering has gone from 41 to 42 million persons in 1990 to 66 to 68 million in 2019, counting decedents and non-decedents. 75 to 80% of these people live in the low and middle income countries that have the least access to palliative care. And as you saw in the map, serious unmet need for pain medicines. COVID-19 has only exacerbated the situation, devastating even well-resourced countries and their health systems, laying bare fragile countries and fragile health systems. The tsunami of suffering has and will be exacerbated in terms of the scarcity of pain medicines. Has because of diversion to COVID-19 patients, will because we're seeing later diagnosis, and therefore for non-communicable disease, we'll see more need for palliative care, more need for opioid medicines. What is happening with distributed opioids in our world? This is showing you the difference between morphine, pethidine, oxycodone, codeine, fentanyl, and hydromorphone. They are data from the International Narcotic Control Board, again, 1990 to 2019. And first of all, look, low-income countries, 166 kilograms compared to 300,000 in high-income countries. But the real focus of this slide should be on, yes, moving away from codeine, but consider this difficult movement not towards more morphine, but towards oxycodone and fentanyl, the more expensive varieties. What can we do in terms of policy? Let's pivot to that. The blame has been placed on opioids instead of on improving governance, public health policy, and education. It is time to heed the long-standing admonitions to improve access to opioids for the relief of breathlessness and of pain throughout our world. Why do I say this with such conviction? Because Germany has the highest opioid consumption per capita in the world, but does not have a crisis of non-medical use of opioids. What do we need to do in terms of pricing and financing? First, patented, expensive products should no longer be favored over generic and expensive, immediately released morphine formulations. Second, medication subsidies and inclusion in essential medicine lists should be based on evidence, on efficacy, safety, and affordability. And finally, opioid medicines should be entitlements covered by public insurance as essential components of basic health packages and universal health coverage. Education. We need to expand, innovate, and harness technology. As we said in our Lancet Commission report, all health professionals, from physicians to faith workers, require basic palliative care training. Palliative care must be an established specialty in all countries. Online training for medical personnel is required at all levels. Rapid capacity building for clinicians in symptom control and management, and harnessing technology like smartphones and telemedicines to access patients at home. What have we learned from the pandemic? Caregivers, healthcare providers, and health systems can benefit from the extensive knowledge of the palliative care community, and that community is here to help. Finally, on procurement, we need to ensure an adequate and balanced supply of opioid medication to all patients for relief of breathlessness and pain by instituting the simplified procedures of the INCB. 2, build and improve on global and regional innovative financing and procurement platforms and models, such as the Pan American Health Organization Strategic Fund. Third, role models. There are countries that have innovated to ensure access to generic opioids for medical use at low prices and have no reports of diversion or misuse in these programs. Examples, Germany, we already spoke about. But in terms of low and middle income countries, Colombia's Fondo Nacional, an example of a state-run monopoly that works. And Hospice Africa Uganda's partnership with its Ministry of Health, a successful charitable sector morphine manufacturing initiative. Let me close with this. Pain is a pandemic. It affects our entire world. The opioid crisis is an epidemic that affects specific countries. A balanced approach to global and national governance and policy is key to remedying the huge burden of needless suffering that plagues our world.
Thank you, Dr. Knaul, for your key contribution and for the data that you have provided us. And now, with great pleasure, I wish to share the closing message from the WHO Director General, Dr. Tedros.
Excellencies, dear colleagues and friends, WHO is greatly concerned about the persistent lack of medicines for the alleviation of pain and suffering globally. This shortage has been made even worse by severe supply chain disruptions due to the COVID-19 pandemic. Several controlled medicines are essential for cancer care, surgical and palliative care, the management of drug use and neurological disorders, and mental health conditions. They are also needed for patients severely affected by COVID-19, especially those being treated in intensive care units. WHO has identified over 20 medicines with global-level shortages, including 4 used for treatment of severe COVID-19. These shortages have been caused by export restrictions and stockpiling of medicines by producing countries and suspension of air freight and road transport. Low and middle-income countries with vulnerable supply chains and with limited or no local production are disproportionately impacted. Urgent action is needed to ensure that national systems improve access to controlled medicines. We need stronger international cooperation across agencies and civil society to address barriers to access for these essential medicines and to put public health and human rights at the center of the international drug policy discussion. I thank you.
Thank you so much, Dr. Tedros, for your remarks and for bringing our session to an end. And thank you all for listening and being part of it.